Diversity, equity, and inclusivity in nursing practice is our episode topic. Rejoining us as guest is Dr. Anna Valdez, professor and chair of nursing at Sonoma State University, as well as the editor-in-chief of the Journal of Emergency Nursing. In October of 2022, Dr. Valdez joined Dr. Lisa Wolf in Season 1, Episode 5 to discuss structural and implicit bias in nursing practice. In today's episode, we continue that discussion within the broader concepts of DEI. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Anna, thank you so much for joining us again today.
Thank you. It's nice to be here.
So you were on an earlier episode where we talked more about implicit bias in nursing practice, but today we're going to explore more broadly the concepts of DEI. Just for some level setting of everyone that's listening to this episode, what is the difference between the terms of the words diversity, equity, and inclusivity?
There are a lot of acronyms out there. I think one of the most common ones is DEI, which is, as you mentioned, diversity, equity, inclusion. It can also be DEIJ or JEDI, adding the justice to that, which is my preference. I usually do A JEDI, and A is for anti-racism. But there's also like IDEA to include anti-racism, and sometimes you'll see a B too for belonging. And part of the reason for that is because diversity and equity and inclusion are really strategies for achieving an outcome. And so that outcome probably includes belonging for people who are working within the healthcare industry, also improved health outcomes for the communities that we serve, right? So we use diversity, equity, and inclusion and anti-racist efforts to be able to really achieve the outcome of all of our colleagues feeling like they belong in the setting, and also that we're really making advances towards improving health equity. So diversity basically speaks to all the ways in which we're different. And I think in nursing, when we talk about diversity, it's often related to racialized identity or ethnicity, and that's because that's where we identify significant underrepresentation. But it could be a variety of things. For example, in nursing, we have underrepresentation of disabled people, and people with disabilities are often overlooked, as well as people who are across the gender spectrum can be overlooked in that. And then equity is really about having similar outcomes and opportunities, right? It's a little different than equality, where everybody gets the same thing, whereas equity recognizes that we're all unique individuals and that we want to get everybody to the same outcome, right? For example, if I have two patients who have diabetes, and one is a new onset type 1 diabetic who is 6 years old, who is insured, has two college-educated parents, and the other patient who is in DKA is a 45-year-old person who lost their job and is experiencing homelessness right now, doesn't have a place to keep their insulin, doesn't have the money, is having to spread it out as much as they can to be able to cope. Those two patients and families need completely different care plans. They need different strategies, right? Because at the end of the day, what we want is for them to have a positive outcome. So that's an example of how equity is different than equality. We would not want to give them the exact same thing. And then inclusivity is really about people being represented, so that when we look at nursing or we look at our teams or our staff, that different people from all different backgrounds and identities are represented And also that they're represented in a way that values them. That's not like tokenism where we hired somebody because we were missing your ethnicity or your gender. And so we're going to pick you up, but we're not really including you and sharing power with you. And then ultimately, beyond inclusivity, what we want to achieve is belonging, right? And that means that I can show up as my full authentic self and that I feel comfortable and you feel comfortable and I feel valued as my full authentic self.
We had some earlier conversations in our previous episode about the need for more diversity among nursing itself so that we've got a more diverse workforce taking care of diverse patients. And some of those conversations alluded in subsequent episodes talking about academic practice partnerships with Dr. Linda Zeman and Dr. Jerry Mansfield about reaching out and just not looking at your baccalaureate programs, but trying to get a pool of resources of nurses from 2-year programs, from associate degree programs. I'm wondering, as we think about those things, and those have been explored a little bit, from a nursing leadership perspective with recruitment and nursing and getting more diverse workforce, what's going right now across the country? What are we doing right? And where are there still some opportunities?
You mentioned 2-year degrees, so ADN graduates. We still have some diploma grads out there, but I don't think we have any diploma programs. But when we're looking at like associate degree graduates versus BSN, I think we've caused some harm, honestly, through the magnet process of setting the standard at BSN. I certainly have read Aiken's work on this, but what I would say is that she compared magnet hospitals to non-magnet hospitals, right? And so for me, it's hard to attribute that solely to nursing education versus many of the other things that you might see in a magnet hospital, like shared governance. That being said, we know that the vast amount of diversity that is coming into nursing comes in through community colleges. That was certainly true for me. I dropped out of high school when I was 16. I had my child when I was 17. I was extremely poor and living on my own. There's no way I would have got into a bachelor's program. I wouldn't have even known how to do that. But I was able to get into a community college program and I got a wonderful education. And I think I've turned out to be a really great nurse and been able to advance my education. But had that not been there for me, I would not have that opportunity. I've had the pleasure of teaching at all levels from CNA to PhD in nursing. And I can tell you there's very little difference between an ADN program and a bachelor's program. It's really essentially the inclusion of two additional classes, public health and leadership. And many community colleges are embedding community health and leadership things within their curricula. But the nursing outcomes, they're very much the same. But yet we have a lot more diversity and opportunity that exists to be able to advance that education, right? So I think one of the things I would say that is happening that is good right now because there's a shortage is the hiring of associate degree nurses and also helping them to advance their education and creating things that I think we have done well in the last 10 years of making that continuum of education much more accessible. When I went and got my bachelor's, like they made me repeat tons of units. They wouldn't recognize it. It took me 3 years to get my BSN, even though I had 5 years of college and over 120 units. Now, like for example, at Sonoma State, where I work, you can get your bachelor's within 1 year. And we minimize the units. We give you credit for prior work. And so I think that's one thing we're doing well, right? Is bringing everybody into the healthcare system and allowing opportunities for people to advance.
And what you
I
described at Sonoma State, is that fairly common for nursing schools across the country, that this is a growing trend? Or are you the exception or the norm, I guess is my question.
It wasn't on account of me. It was on account of Dr. Liz Close. We were trailblazers in this. We were one of the first universities to, for example, we give up to 30 units of credit for passing the NCLEX because it accounts for all that education. But across California, it's very common now. And I have seen many programs out of my state. I don't have a lot of firsthand knowledge about them. So I think this is a growing trend where opportunities for advancement of education have really been made a lot more accessible for folks. Some of the other things that we're doing is we are starting to look in nursing schools towards holistic review admissions. Historically, particularly at the university level, many schools use a combination of point factors that are very heavily weighted on metrics. So, GPA, entrance exams like the ATI or HESI or the NLN exams, and then other performance things. And what happens when you do that is that people who are highly resourced have an advantage, right? If you lived in a community where you had a really good education and you have family members with generational knowledge related to universities that can support you, and you have access to tutoring for those entrance exams, for example, you've got an advantage over somebody who doesn't have all of those resources. And so, what we found is that we continue to really attract people and admit people who are already very well represented within nursing. And through that process, we exclude folks who are not. And so we are seeing a trend. We're working on that right now at Sonoma State of moving to holistic review, where we look at three factors. It's a EAM model. So experience, attributes, and then metrics. And to do it right, it should be evenly divided. So in that case, a third is coming from those metrics like the GPA. But we're looking at attributes. How well does this person view, philosophy, intentions align with our mission and vision? And then also experience. Do they have prior healthcare experience? Are they bilingual or multilingual? Things like that, which tend to even the playing field. And perhaps, I hope, when we have more data, also help us to bring people to nursing who really do care about and fit with the mission of nursing. Where we're still having problems is both in education and practice is not fully understanding and recognizing the racism and bias that exists. So often underrepresented students who get into nursing program or graduates who go out into practice are still experiencing a lot of racism or other forms of bias. And that harmed their spirit, it harms them professionally. And so we've got a lot of work to do, I think, there. And the other area where I recently really became more aware that we have a lot of work is in pre-nursing. And it's something I had not focused on much, but my daughter, Mia, happens to be a pre-nursing student. And so I've watched her go through her prerequisite experience, and there's a lot of bias and shifting people, particularly people who are from the global majority who are racialized as non-white, into LVN programs. Or, for example, my daughter had a class where her and her friend is African American, both took the same exam, had almost identical answers, and my daughter got it right and her friend did. And so there are still some issues out there around bias that I think help, start to exclude and eliminate people from even applying to nursing school. We have to work on that. That pre-nursing, I'm actually going to work on a study on that. And we have to work on how we're admitting people to nursing school, how we're treating them when they're in there, and how practice is prepared to be able to make sure that when we bring diversity in nurses who are underrepresented, whether that's disability, gender, sexuality, whatever that is, that we're bringing them into safe settings where they're going to be valued and respected.
So we'll talk more about practice here in a moment. I want to circle back to your comments about Magnet. And I think it was Jerry Mansfield and I that were talking about the percentage BSN completion. Maybe that's not a fair assessment. Why not instead look at health systems and hospitals that are promoting the advancement of education while they're there? Who cares that you have 90% BSN completion? Isn't it more value added that you've got a number of students or a number of employees that are all in some form of educational journey? If you're employing LPNs, you've got an RN completion program, and this is the percentage that are there. If you've got RNs that don't have their BSN, you're offering a mechanism for them to go back and get their BSN. If you've got BSN students or BSN completion nurses, you're supporting them in developing their masters. And all of this is when the different individuals are ready in their own journey in adult education. Maybe they have other life circumstances that say that they need to take a break and not go from one program to the next in a sequential fashion, that they need a 4 or 5 year break because they just want to work in and take care of their newborn children or something along those lines. And are we measuring it really the right way when we're just looking at BSN completion rate? And is there a better mechanism out there to look at quality education and development of a workforce within an institution?
I'm a huge advocate for academic progression. I've done a lot of work with that, like with the organization of associate degree in nursing. And I think that is a really important variable. Hire people with ADNs. And I'm even in support of setting a time frame, like you need to get your bachelor's degree within 5 years or within 10 years. And we have these academic partnerships where we can support. There are some practice environments where they actually do university classes on campus, right? The university comes to them and they have night classes or whatever. How are we supporting academic progression, both financially and with time and with resources, but also helping to push nurses forward, right? And also part of that is about succession planning too, right? We want to be mentoring and growing people towards leadership roles and things like that. So I think that's a really great point. I think that measuring where your staff, where your grads are at, and what their goals are, and how you're supporting them in doing that, and how many of them are completing that goal, I think would be a great measure.
On the practice side, thinking about minority populations working in a healthcare environment, what are successful structures and support mechanisms for those minority populations? If I'm an executive, how do I, and particularly me, look, I'm a white male. If I'm a nurse executive, how do I know, especially being from a non-minority population, how do I know I've got the right mechanisms in place so that all healthcare workers, all employees, and frankly, all patients for that matter, are in a healing environment and a place where racism is not present? And when there are instances of it being present, it is addressed appropriately.
We're moving away from the term minority, although you see that all over the place, right? Even with NIH grants and things like that. And that's because, in part, the connotation minority theoretically means less than. I know that we're using it in terms of underrepresented. I use minoritized populations if that's what I need to share, but also people of the global majority, because that recognizes that actually people who are racialized as non-white, and remember that race is a social construct anyway, but people who are racialized as non-white are actually the majority of the world. With that in mind, I think some of the things that nurse executives need to understand is, first, racism is happening in your organization. That nurses who are underrepresented experience bias and oppression. We know this if you look at, for example, the National Commission for Addressing Racism in Nursing survey, or the recent Robert Wood Johnson Foundation survey. We know that overwhelmingly that nurses who are minoritized as non-white or who are racialized that way are experiencing pretty significant and profound racism. Dr. Lisa Wolf and I talked to you about our study specifically looking at emergency nurses, and we found that nurses overwhelmingly observed bias and experienced bias. So I think the first thing is nurse executives have to say, this is a problem in our organization, and recognize that, right? And not assume that you're doing everything. I think listening to the people who work with you, climate surveys, one of the things that's always frustrated me, I've done many climate surveys throughout my career. I have never once had people come back and say, these are the areas where we're falling short, and this is our action plan, and here's our timeline for us to be held accountable to addressing those climate issues. I also think establishing a environment where challenging bias is the norm, where it's expected, right? Where every time you do a report, you ask each other, what are the potentials for bias here in this case with this person? How are we forming our judgments? Are we doing that based on what the patient says, or are there derogatory things in the record? So really normalizing people being comfortable saying, hey, Anna, I noticed that you're not giving the pain medicine to this patient and they seem to be in a lot of pain. I'm just checking in to see if there's anything I did to help you. Is there a reason why you're not addressing their pain? Is there a potential that there's some bias? I've had people ask me, or I think maybe you're being biased here. I really actually appreciate that. It gives you a chance to reflect. So creating a culture where really anti-racism and equity and inclusivity are expected, right? That's the norm where we challenge each other, we hold each other to account for that behavior. And oftentimes it may even be implicit behavior, right? Or based on implicit biases, but making it the norm. And I think also having policies. One of the things that I was really surprised by with the study Lisa and I did was that nurses did not report bias overwhelmingly because particularly nurses who experienced bias, they were often reprimanded for bringing it up. Like the patient called me all these derogatory names. And it's like, what did you do? Why isn't the patient happy? Kind of thing. But nobody had policies on what to do if a patient, for example, refused a nurse because of their racialized identity or because of their sexuality or their gender. None of them had policies. So it's like haphazardly happening out there. What policies do you have and process do you have if a patient raises concerns that they're getting biased care or racist care? What are the processes? What is built into your system in terms of how to handle that? So it's not just being handled subjectively by one person who may hold the same biases.
Dr. Garrett Chan said it's very important to acknowledge the feelings of those in the majority population as DEI initiatives are rolled out and move forward because there can be a sense or a perception that there is a taking away that exists there, and it's not intended to be reductionistic. It's intended to be additive for the benefit of all, not for the withdrawal of the majority. And so I guess what I'm trying to ask is how do you thread that needle from a sensitivity perspective, or don't you? Do you just blaze ahead, and what are the repercussions on either end?
So if I'm understanding what you're saying, and I appreciate that you're doing this with sensitivity, is that DEI efforts, and we've certainly seen this politically, right? We've seen this across the United States landscape. DEI activities can make people who are racialized as white feel like somehow they are now being excluded, something's being taken away from them, that this kind of concept of reverse racism or being discriminated against, but also just pushing out of comfort, right? For us to recognize and say, yes, racism happens here, oppression, bias happens here, that requires us to self reflect, right? Like, how might I be contributing to poor health outcomes or to bias? And so I do think it's a little bit of both, right? In threading that needle, which is a fine needle to thread, is how do you move forward with intention and meaning and really do this work so we can create equitable and inclusive environments, safe environments, healing environments, but also not lose the dominant group within nursing and within healthcare who really has to be involved in helping to push this work forward, right? If the dominant group within nursing or within healthcare is not committed to the work addressing bias, anti-racism, improving health outcomes, if they're uncomfortable with the language and those things, it's very hard for us to move forward, right? We can do this work. But honestly, this is really the work that needs to be done by people who are racialized as white, right? This is a problem that originates from kind of an indoctrination within our country. But what I find in nursing is that nurses have a really hard time, especially nurses who are racialized as white, with recognizing that racism is a problem. And I think that part of that is because when we think about racism or bias, we think about that from an interpersonal standpoint, right? Like I am biased against you, or I am treating you unfair or providing biased care. because I don't like your ethnicity, your racialized identity, whatever. But really, that's a super narrow view of bias and racism. And it doesn't account for things like internalized racism, stereotypes, bias, both from people who have experienced it and people who may not even realize that they have privileges or things like that. And then organizationally and systemically. And so one of the things that I think is really important is understanding all the type of bias and racism that occur and at what levels and how that shows up. Because what I get from nurses all the time is I've been a nurse for X amount of years and I've never seen racism. And that's always from nurses who are racialized as white. And it's, I think, two things. One, they're not experiencing it, but two, they don't know what it looks like because life looks very normal and comfortable. And so I think when we can be very direct and push forward, yes, you do blaze forward, but also creating situations where you can give real exemplars, right? What I find is even nurses who start with saying to me, racism is not a problem, bias is not a problem. I treat everybody the same. When we go through case studies and examples of ways in which people have been harmed and had poor outcomes are like, wow, I didn't realize that. What do I need to do about that? But also I think part of it is when you recognize that something's a problem, as a nurse, we have an ethical and moral duty, right, to do something about it. If you saw me making a medication error, you would stop me. Even if I was grumpy and been a nurse for 40 years and you were a new nurse, you would still stop me before I made that error. But we don't do that when we're doing biased care or things like that. And I think it's partially because of discomfort. And so I think that you have to, in doing this work, you have to understand that people will be uncomfortable. And I also think you forewarn them they're going to be uncomfortable. And you create opportunities to talk about that discomfort and push through that discomfort. And also creating the situation for people to be able to see it, right? If you don't know what bias looks like because you haven't experienced it, if you don't know what it's like to not have the same privileges, you don't know how to recognize that.
If I'm a nurse leader and I know that I need to do more work, but I don't know where to go, what's a few resources that I should take a look at to help me guide me in terms of next steps?
National Commission for Addressing Racism, doing some great work, have some really good resources. Joint Commission for Practice Environments now has a health equity certification. Consult with some of those programs. So we just had the first round of hospitals, many on the East Coast, but first round of hospitals who got that certificate. Check in with your colleagues to find out what they're doing to be able to advance health equity. The Campaign for Action and the work they're doing with AARP is great. And then also I think the Robert Wood Johnson Foundation is doing a lot of really good work around health equity. And there's great resources in all of those areas.
Any closing thoughts as we wrap up this episode?
We must do this work. It's critical to what we have committed to do. It'll be a little bit uncomfortable at first, but move through that, right? Move through the discomfort. Remember at the end of the day what our mission is and what we're trying to achieve.
Diversity, equity, and inclusivity in nursing practice has been our episode topic. We will certainly be continuing to address this topic through a variety of different episodes in the future. Dr. Anna Valdez, thank you so much for your time today.
Thank you.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.